You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS, and today we're talking with Megan Solinger, Director of Services and Care Delivery at the Ullman Foundation in Baltimore, Maryland, about how to have challenging and complicated fertility discussions with your patient. Megan presented the topic at the 47th Annual ONS Congress in Anaheim, California on April 28, 2022. You can also earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thanks for joining me today, Megan.
Of course.
So to start us off, let's talk about the importance of having fertility preservation conversations with patients with cancer. I think this is something that a lot of nurses maybe aren't sure how to start that conversation or really feel that it's an important one to have. And are they the ones to have it with their patients? So talk about why oncology nurses need to have these discussions and be comfortable with them, with their patients.
I'll start with saying that the adolescent and young adult population, which is the ages 15 to 39, those are childbearing years. So anytime you have a patient within that age range, you should automatically have sort of a flag going off or some sort of internal alert to say a fertility preservation conversation or conversations need to be had with this patient. And so as a nurse and as someone on their care team, we always assume other people are having these conversations, but as their nurse or as someone who really genuinely cares about this patient, we should care enough to bring this conversation up to them. I think that there's a lot of importance to having many people bring it up so that they realize it is a big issue and it's an important issue. And so never assuming that someone else is having the conversation is probably the biggest piece to make sure that this is brought up early and brought up and giving the patient plenty of time to have the conversations they need to have.
That's a big age range. And I think that folks don't always think about what that really age range is. And that's a lot of patients that we might be dealing with. What are some of the barriers that might prevent an oncology nurse from having a fertility preservation conversation with a patient?
There are lots of barriers, and it's not just on the provider, it's not just on the nurses, it's also on, from the patient side as well. But in particular for nurses or anyone on the care team, we all have our own personal biases, and we may or may not realize how they're playing into how and the types of conversations we're having with patients. For example, fertility preservation can be a polarizing, but it's also just a very emotional and challenging conversation to have. So a lot of times we don't have these conversations with our patients because we're nervous. We don't know enough information. We make assumptions about the patient. So those inherent biases that we have can really affect whether or not we're giving the patients the information they need to make the decisions that they need to make, either regarding treatment or what happens prior to treatment. Other biases may be, like I said before, we may just not know the information. So not being prepared and not knowing what options are for patients, let alone what is fertility preservation and how it works, can all prevent us from having these conversations with our patients. And assumptions get us in trouble. We assume that someone else is having this conversation, so we don't have the conversation. We basically make up excuses for why someone else is having this conversation so that we don't have to have it ourselves. And that's honestly detrimental to the patient, who should be first and foremost the most important person in the room.
Exactly. And I think some of that might be because of the age range of this patient population. I think sometimes, whether it's the care team or the patient and the family, you get this diagnosis and think, we've got to start treatment right away. Do we even have time to have that conversation? And if we have that conversation, are we going to be delaying something? And what does that look like? I think for the nurse, because she is the one who has the ability to make those connections with the patient, it's a good place for us to really understand and be able to advocate for the patient with the care team when that plan is being put in place.
Absolutely. I mean, I'll just add that the ASCO guidelines came out in 2018, and they really took the burden of who should have this conversation off of just the oncologist and really made it general to say someone on the care team, a provider. So that can include, as we know, the care team is very multidisciplinary. And so there's the opportunity for institutions to say, okay, this is the particular person that should have this conversation. But the burden, regardless, falls on every single person on that care team to make sure that that conversation is had.
That's really good. So, what are some of the key topics or discussion points that oncology nurses should address during fertility preservation conversations?
I even think before having the fertility preservation conversation, we need to do a little bit of research. I mean, we obviously know we need to look at a patient's chart to make sure we have relevant and solid information. I would say, in particular, running into issues with gender and sort of who we're talking to, and also any other known health issues. So, just being prepared is a really big thing we need to do before we even have the conversation. We need to know resources so that if we need to refer out, which most likely we will, what are the resources in our hospital? What are the resources in our community when it comes to fertility clinics and either labs and things that need to happen before a patient can actually preserve? We also need to understand our own biases. Like I said before, we make assumptions. We don't want to have this conversation. And we assume that because a patient has 5 kids already, they don't want more. So we're not going to have the conversation. We assume that, oh, we know this person is really strapped for finances and really struggling. They're not going to be able to afford it. We should really just kind of go in with a clean slate and understand that it's an ethical issue. It's a survivorship issue. It's a all-encompassing issue to have this conversation with patients. And so we owe it to them to have it. So there's obviously preparation to go in, but once you go in and have the conversation, it's really introducing the topic. What I found is that a lot of patients and families have no idea that cancer and or treatment can have any implications on someone's fertility or the possibility of making them infertile either permanently or temporarily. And so just bringing it up, you're probably going to get a lot of patients who are like, wait, what? Something else to consider on top of, treatment and just being diagnosed. So one thing is just really kind of understanding their level of comprehension when it comes to fertility preservation, their health literacy, and really just how to explain what fertility preservation is going to be some major discussion points and probably take up the bulk of the time. And then also just helping them logistically, if they want to go through this, how to make the referral, how to get the labs done. It can be very technical and logistic heavy, but it's really important to get it done properly. And then I would say lastly, when it comes to the discussion is making sure the patient understands what was just discussed. I think nurses do a fantastic job of using the teach back method in this particular conversation. That shouldn't change. That shouldn't be any different. And so asking patients and their family, if there are other family members in the room, what they understood to be the key points, the takeaways, and what they would like to do are all going to be things that it's really important to put back on the patient, have them verbalize to you. And lastly, I would say just confirming what their decision is, whether that's right in the moment or giving them some time, whether that's a couple of minutes, hours, or a few days to make the decision, depending on what their particular circumstances are, is going to be really important. And then reconfirming and confirming again that that's their decision. So those are the couple of, if not many things that you should consider when having the discussion with your patients.
You brought up some really good points about making sure that they understand and kind of having that teach back so that you can ensure that you have covered all of the information about fertility preservation and what their concerns might be, and giving them the opportunity to ask you more questions as well.
I mean, asking questions is going to be big. And I always say it's okay. And to this day, when I have fertility preservation conversations with patients, I get stumped. And it's okay to say, I don't know, let me look into that, because every circumstance and patient is going to be unique. And so if we understand at least generically and generally what this process looks like, we can at least answer those questions for our patient. And then specifically, if it's something very clinical or technical, we can obviously refer to the experts in reproductive endocrinology or whatever types of questions they're asking and refer to a specialist. I think it's our job to understand the basics and be able to give them really good information about what this process is, why it's important, and what things would look like if they decided to pursue or not pursue fertility preservation with regards to their fertility.
Again, kind of that whole, if this is right at the beginning of their diagnosis and they're kind of trying to wrap their head around in just learning that they have a cancer diagnosis and then bringing this up, that's a lot of information for patients to process and to, think, how am I going to make that kind of decision right now when I have this other decision to make too? So just lots of emotions and feelings and everything going on with all of that.
Yeah, and that's the other reason why you should have this conversation multiple times. I can tell you that I've had patients where I have a fertility preservation conversation, I document it in their chart to say that we've had it, that they've declined, that I've checked multiple times, and I've let the care team know they can start treatment. Fast forward a couple of years, treatment's done, they're into survivorship, or maybe they relapse. And they're like, I don't remember having this conversation. So even if we do have this conversation multiple times, there is so much going on. And when emotions are high and someone is basically told they have cancer at a young age, and it's obviously very unexpected, that can wreak a lot of havoc. And we're just not thinking straight. So it's not a bad idea. And it's highly encouraged to have this conversation multiple times.
So talking about having the conversation, fertility may be a difficult subject for both patients and providers. How can an oncology nurse begin the conversation with their patients and help them feel comfortable during this conversation?
One of the biggest things about having the conversation is if you walk in, obviously with any conversation, this is true, but if you walk in nervous, they're going to be nervous. If you walk in and normalize this conversation to the best of your ability, and obviously it gets easier over time, they're going to be much more relaxed and receptive to this conversation and this topic, which is very difficult. I would say walking in and having the conversation, asking a simple question, has anyone talked to you about fertility preservation? And obviously, if they have never heard those two words together, they're going to have this puzzled look and say no. Even if someone has it, they're like, I kind of remember it. They'll give you an idea or an indication whether or not this is something that they have a lot of knowledge on, they have zero knowledge on, or they only have a little bit. And you can kind of take it from there to go into detail and to reiterate any key points or specifics to their circumstances in pursuing fertility.
As the person having the conversation, if you're nervous, like you said, that's a really good point and something for us to remember.
Yeah, and it's also not using big words that they may not understand. I mean, tailoring the conversation to their level of understanding. We talk a lot about health literacy and, really having things at an understandable and relatable level, not using big words. But sometimes it also requires to be very descriptive and use words that are uncomfortable in day-to-day conversations, and just getting comfortable saying things to patients that are very matter of fact can really help with the conversation and describing what the process is. I'll give you an example. I mean, for men, walking into a room and telling them that they have to masturbate in the hospital or at home and create a sample, just hearing that word makes men cringe, makes women cringe. I mean, it's an uncomfortable word. But if you go in and you're matter of fact and you can be straightforward about it, they're like, oh, well, that's just the process. I mean, it makes it a little bit less awkward and more relatable for the patient to really understand what the process is for them, and that it is a technical and clinical term, but something that they do understand. So that's just an example.
Thank you. That's great for giving that example. So we've talked about how to have the conversation and the importance of it. Let's talk a little bit about when this conversation should be had with a patient during their whole treatment journey. When is it best to have this conversation?
Basically, the guidelines say that within 24 hours of a diagnosis, someone should have a fertility preservation conversation. Obviously, that's in a vacuum in an ideal world, and there's so many other things happening. The key point is that the conversation should happen as soon and as early as possible. I would say as soon as we have a confirmed cancer diagnosis, if they're still working up sort of the subtypes or anything like that. But once they have a cancer diagnosis, it's absolutely appropriate to have this conversation, especially once things start spiraling and treatment plans start happening and labs and tests and scans. Getting in there when you can, the earlier, the better. The idea with fertility preservation conversations and sort of that consult is that you have it before treatment starts. So that's the key and the operative piece that you're operating under, is that this conversation, if not once, multiple times, happens prior to treatment starting. And even once treatment starts, maybe someone, you didn't have a chance to connect with someone or no one had the conversation with them. I mean, you can have it and should have it at multiple points along the cancer continuum and not just waiting until someone is in survivorship after you had it right when they were diagnosed and nothing in between. So ideally, before treatment starts would be the easy answer. And then it's totally appropriate and okay to have it multiple times during the cancer continuum.
That's good to know. And so you've mentioned, as we've talked earlier, about the nurses having discussion points and trying to make sure that their patients understand the discussion that they've had. But how can a nurse prepare to have this discussion with their patient? This is the first time that they've met this patient, or maybe they met them earlier the day before or something like that. But how can they prepare and be ready to do this?
Preparation, like I said, is huge. And that is going to be a big predictor of success of this conversation, not necessarily success of whether someone does fertility preservation, but that they make the right decision for them. So in terms of preparation, I mean, a couple of things come to mind. There are a couple of training programs out there. One of them is the ECHO Navigator Training Program, and it's all about enriching communication. It's a free 8-week virtual training program to help providers with the communication of how to use and have a timely and relevant conversation related to oncofertility. It usually happens January through March every year. So just applying online and doing that program has probably been one of the best training programs that I've done. There's the Northwestern Oncofertility Consortium. So they have lots of resources. They have a navigator if you have any specific questions to ask, but it's a great resource. And then one of my favorite websites is called letstakecharge.org. And it's put on by F Cancer, and it's really created for patients. But there's no reason that providers and just people who want to understand what oncofertility or fertility preservation is. And they have really great description of what options are for men, what they are for women, what they are if you're prepubescent versus post-pubescent, a bunch of resources. So really just understanding and looking at some visuals and really digestible information. Those are probably 3 great resources that I would probably recommend to look at and prepare yourself. And that's kind of at a high level, like what is fertility preservation? What are my options? And then specifically knowing at your institution and in your community what the options are for patients when it comes to referring or getting expert information from a reproductive endocrinologist. So where to send patients? What does your institution have? Something specific to your community is going to be really important to make you successful in making those referrals in a timely manner.
Thank you for that. I think those are important things for nurses to know where to get that information. And also, like you said, the one was specifically for patients, just being able to refer our patients to some of those locations, because sometimes they might be, as you said, we mentioned earlier, they don't remember having the conversation, but if there's somewhere to go back to look at or be able to review again is important.
Yeah. And then if you're looking for, again, to help you build your knowledge of local resources, there's the Alliance for Fertility Preservation's website. They have a resource called Fertility Scout, and it's a searchable database. And you can search for, if you're looking for a specific type of fertility preservation resource, whether it's for men or women, whether it's cryopreservation or egg harvesting, any resource specifically to your patient, you can look it up by zip code and kind of see what brick and mortar and also other resources are out there in your community. So that's a great searchable database that can really help you get started as well.
So you mentioned earlier our own personal bias on things. What are some ways that implicit bias can affect fertility preservation conversations with patients?
We all have implicit biases. We all have things that we come to the table with, our own values. Sometimes our religion gives us, a lens to look at things through, and it may not match what the patient and their family, what their values and understanding of things are. And so it's really important to just understand having biases really prevent us sometimes from being able to have honest conversations with people. And that's really ultimately what we're trying to do. We're trying to give patients the best information, the most information in a timely manner for them to be able to make a decision that's right for them. And so we're not projecting our own personal biases on them. We're not making the decision for them. And so just really understanding that our job and our goal, regardless of how we personally feel, we should go in wanting to just educate our patients to the best of our ability so they can make the best decision for themselves, an informed decision.
So what would a nurse navigator's role be in ensuring that the cancer care team has fertility preservation conversations with a patient?
My experience, a lot of times, the nurse navigator, the nurses, the interns, depending on your institution, there's so many different people who are helping decide what the treatment plan is going to be moving forward for this patient. And so making sure that we're not silent. I would say that silence is going to be very detrimental, and speaking up on behalf of the patient, whether you've met them or not, to the care team, especially being part of a multidisciplinary team, and letting the care team know that this is something that needs to happen, and making sure the correct people are on board, that if there is a delay in starting treatment, that that's okay, or that it's communicated. And just really speaking on behalf of your patient is going to be really key here. And so, just having that understanding that there might be, for a woman, it takes 2 weeks to potentially do an outpatient egg retrieval. And so just really being able to communicate that to the team, because in my experience, not a lot of people know about the process and what the logistics are and the timeline for fertility preservation. So just being the advocate for the patient, as they're discussing treatment, saying, we'd like to start treatment tomorrow, and this is the treatment plan, and coming in and saying, I would like to have the fertility preservation conversation with the patient, and I'm assuming that they are interested in it. This is how much time they'll need to complete it. So really just speaking up and at least allowing the team to understand that fertility preservation should be one of the first things that happens, and try to pursue it if possible and not detrimental, obviously, to the patient's health.
We talked about the nurse navigator's role and making sure that where they sit in having that conversation or ensuring that that conversation is being had. But really, the oncology nurse is probably in a perfect position to be part of that care team and be the advocate for their patient, as you mentioned, to make sure that that conversation is happening. I think that with our listeners, there could be a lot of listeners that may not have a nurse navigator in their practice or in their setting. So this may fall to them to be the one that is bringing the patient voice back and advocating for them when those discussions are happening.
It doesn't have to be a nurse navigator. And again, it's really people who build relationships with their patients are going to be able to have conversations that other people won't, and they'll be able to understand exactly what the patient and their family wants and desires. It's really about building trust and rapport with the patients, regardless of someone's title. I think just understanding and working with your patient and meeting their needs and meeting them where they are is going to be really important. So if you know the patient and you know that you have the rapport with this patient and the family to have this conversation, then have it. There's no harm in having multiple people have it, but just having it builds a rapport. I say it's like the ultimate icebreaker. Walking into a room right when someone's diagnosed, you haven't had a lengthy history with them probably at that point. And so going in and saying, hey, I'm so-and-so, I'm your nurse, I'm your navigator, I'm whatever on your care team. Has anyone talked to you about fertility preservation? It's the ultimate icebreaker. And so if you can have that tough conversation right when you meet someone, it's going to have a ripple effect, and they'll be able to go to you for other hard conversations and issues down the road as well. The other piece is, I think anybody on the care team, especially if they are sort of like that consistent piece in the care, they're perfectly primed to have this conversation and have follow-up conversations. I think it's all about comfort, especially because it is a tough conversation. So, if you know that you're going to be their nurse every time they're inpatient or every time they're in infusion, it's a great way to build a rapport and be able to have that conversation because you are a familiar face or will become a familiar face.
So I'm going to shift gears a little bit and talk about different patient populations. Fertility is really an important quality of life concern for that adolescent young adult, we'll say AYA, call them the AYAs now, who are receiving a diagnosis of cancer and going to be beginning cancer treatment. How do the conversations differ for this AYA population from other populations?
I think having developmentally appropriate care for your patient is going to be really important. And the adolescent and young adult population itself comes with really understanding where this person is developmentally, because again, as you mentioned before, 15 to 39 years old is a really wide age range. And then even within that population, the AYA population, there's a lot of variation in terms of people's developmental stages, milestones, coping mechanisms, emotions. Everything is sort of in a developmental stage at different points in time, because we're still developing at that point. I mean, our brains don't develop until we're 25. And so, talking to an 18-year-old versus a 35-year-old is going to be very different. And also life experience can vary as well and play into effect in terms of whether they're even thinking about families or having an education where they have the exposure and life experience to know what fertility is or to know what some of these things are that we're talking about. So having developmentally appropriate care or conversations and communication is going to be really important. Thinking about whether or not the patient is a minor or not is going to affect how you and who you have the conversation with. Obviously, if someone's over 18, you really are only obligated to have the conversation with the patient themselves, and speaking to anybody else about their medical care or sensitive subjects is taboo and not okay. And so just running that by the patient, but also involving the patient if they are under 18 and kind of building that rapport and trust and making sure, even though they are a minor, that they still are hearing and that you're talking to them and respecting and honoring their decisions and their choices. So within that age range and that population, there is a lot of variation and just really kind of probably an overused phrase and a little cliche, but it's so important to understand is meeting patients where they are. That's probably the biggest thing. And it's really understanding a little bit more about them and what's most important to them so that we can honor their decisions and make this, a relatively smooth process and something that's as comfortable as possible for everyone involved.
So are there any specific resources that oncology nurses can provide for the AYA population? And even before you answer that, I think one of the things that you said in answering the last question, you have to take into consideration, that AYA population, again, is a very, very wide range. So where are they in that range? And are there going to be different resources? Even we're talking the AYA population, but within that population, are there different resources that would be appropriate at different points for those ages?
I don't think within the AYA population, there's necessarily different resources. I would say the biggest difference in that population in terms of just options for fertility preservation are going to be dictated by whether or not the patient has hit puberty or not. And that's really going to change the whole nature of the conversation. And again, 15 to 39, most likely, and in most cases, your patients have hit puberty. But if they haven't, that's a completely different conversation. And all of the options for patients who have not hit puberty are experimental at this point. And so having an institution and knowing if your institution has any of these experimental options are going to be really important for the prepubescent patients. And so that's going to change completely what resources and your conversation that you have. So I would say once someone has hit puberty, the resources are probably going to be pretty similar in terms of describing the process and logistics. But other than that, I think the resources are pretty similar. For me, the difference also comes into play if someone is inpatient versus outpatient, and understanding what resources your institution have, that may change what resources are out there for your patients and what their options are for pursuing fertility preservation. So just options might change whether or not the patient, especially if they're, for example, a leukemia patient and they're admitted and treatment needs to start yesterday, they're not likely to be able to be discharged to go to an outpatient clinic to get fertility preservation. So just understanding inpatient versus outpatient resources is going to also be a little bit different. And also male to female, inpatient versus outpatient is going to be a little different.
That's good to know. We're talking about special populations or different populations. So how do fertility concerns and conversations differ for other special patient populations?
When it comes to special patient populations, I would consider people who might have an infectious disease to be a special population that we need to handle slightly differently or just with a little bit more care. Believe it or not, patients with infectious diseases such as hepatitis or HIV/AIDS, they still can pursue fertility preservation, which is something I didn't realize when I first started doing this, but they can. It's a matter of giving the lab a heads up and working with them to coordinate the transportation and then they have special storage for those patients. It just probably the cost of it for storing their sample is a little bit more. So when I work with patients who have special circumstances, special patient populations, I try and see what the options are. So HIV/AIDS patients might be, and infectious disease patients are a population that just need to be handled with a little bit more close communication and coordination when doing fertility preservation. That's just one example of a population that might have additional needs.
Megan, I want to thank you for being with me today. This has been a very interesting conversation, and I think one that a lot of oncology nurses, probably all oncology nurses, need to hear and want to understand more and want to probably be more comfortable with to advocate for their patients. So, as we're coming to the end of our conversation, there are just some questions that I like to end with each podcast. And the first one I have for you is, what are common misconceptions about fertility preservation conversations?
One of the probably major misconceptions that people have is that someone else is having the conversation on the care team and that the conversation then never happens because we all assume someone else is doing it. That's probably a big misconception about how it's handled with communication or the lack of communication. I think misconceptions are that the timeline, I find a lot of oncologists and care clinical teams don't understand the process. And so they assume that this process is something that can happen really quickly, especially for a woman, when in reality it takes 2 weeks. And so we have this misconception of what the process really is when we say fertility preservation. And we also assume that a lot of providers assume the cost is much less for our patients than it really is. And so I think there's just a lot of misconception about what this actual process is and what it entails.
What's something about having fertility preservation conversations that is not often discussed, but you wish people knew more about?
I think when we have these conversations, it's not often discussed that we're just adding more uncertainty. I sort of think fertility preservation is like an insurance policy. And it's one thing that in the conversation, we're giving the patient the power to make a decision when a lot of other things in their treatment plan are sort of dictated to them. And so letting them know that they really ultimately do have the decision making power in this, I think is really important. I think we sometimes are so logistic heavy and we're so keyed in on education that we forget to let the patient know this is ultimately their decision. And I think that just having the fertility preservation conversation, honestly, is something that I wish happened more. Ideally should be at 100% of patients or up there that, someone on the care team is having this conversation. So I wish more people would even just have this conversation, as awkward and as hard as it is to have. And that would be my ideal goal.
So, what additional training or education do oncology nurses need to have fertility preservation conversations with their patients?
In order to have a fertility preservation conversation, I think we need to understand what our institutional and community resources are. But before we can understand what those are, rather than just telling patients what the resources are out there, we need to understand what the process is itself. So I would just say understanding what the options are for men, the options are for women, and then diving in a little bit deeper to where those resources can be found for each of those populations is going to be really helpful in giving you the best information to give to your patients. There's a couple of online training programs. There's a lot of research out there about fertility preservation, but I would say there's the Oncofertility and the ECHO training program, the Oncofertility Consortium, the ECHO training program, and Let's Take Charge are three of my favorite resources and training programs.
And are there any additional resources for patients or providers who want to learn more about fertility preservation?
Again, I think when it comes to resources, the three that I mentioned before are going to be really important. There's a lot of clinical articles, especially depending on how involved or how much you want to know about the process. But I always, when it comes to additional resources, I've had a lot of good relationships and conversations with reproductive endocrinologists to really understand what the process is and maybe just trying to get a deeper understanding of what the options are so that I can boil it down for patients to really understand logistically. So having an expert in my back pocket that if I get also any really tricky questions are going to be important. So just knowing who you can call and rely on to help educate yourself, which ultimately helps the patient, is going to be really important.
Great. Well, again, thank you, Megan, so much for joining us and for helping us with this really important subject and the information that you've provided to our listeners. I know that it'll be very valuable for them. Do you have any final comments for us?
I appreciate you just wanting to learn, and everybody who's listening wanting to learn a little bit more about fertility preservation. That's the first step in really being able to help yourself and help your patients. There's so much more to unpack, but this is a great start, and I hope we get to continue this conversation.
Thank you. Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you downloaded your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.